Good evening. I'm Professor Ian Hickie. I'm the Co-Director of Health and Policy at the Brain and Mind Centre at the University of Sydney. Thank you for joining us this evening for the second of our webinar series on flattening the curve, the mental health curve that is, in response to COVID-19. This is part of a wider series we've also had about digital mental health, so-called Flip the Clinic. In these COVID times, we're now doing things very differently. Tonight, however, we want to focus on a major service challenge that we face, and that is in relation to the COVID-19 crisis. We will inevitably see increased pressure on our emergency departments. They're the place where the light's on and people are home 24/7. Prior to COVID-19, we already had increasing emergency department presentations of young people in particular who could not find adequate care elsewhere. We're going to hear from a variety of people with lived experience and particular innovations in this area shortly. I'm joined by a panel of presentators tonight, which include a range of professors and some of my favourite people, including Joanne Atkinson, Joe Robinson, Simon Judkins from the College of Emergency Medicine, John Mendoza, Pat McGorry, and Elizabeth Scott, who's joined me here in our lounge room as we go to the world from our own particular places. I would like to start by also recognising the Gadigal people of the Eora Nation, and myself and Elizabeth are sitting in a beautiful part of the world in Sydney, which is the Gadigal people's world, where the University of Sydney also has its principal campus, and also to pay our respects to those who have lived experience of mental health problems. If you're joining us and you have questions you wish to ask, you can use the Q&A function, and I'll attempt to reply to many of those as we go, but also bring them to the attention of our panelists. So some of you will be aware that we have created some degree of national interest in the mental health curve, the second curve, and the predictions about the size of that curve. That's caused a degree of disturbance to some, that the idea that we simply are saying things will get worse may cause our system to come under more pressure. Our system will come under more pressure. The reality of these situations is, I think my own view is, we're in the eye of the storm at the moment. We've been, through good fortune and good governance, been able to dodge the bullet of the health crisis of COVID-19, but the economic recession effects and its effects on mental health and the ongoing mental wealth of our nation is a major challenge. What we're looking for is solutions. What we're looking for is innovation. What we're most looking for is a coherent national response. And in order to inform that, we'll shortly go to Professor Joanne Atkinson, who's led that modelling. But for all of us, there's a real world element of this. And so very kindly this evening, David, who is the parent of a teenager who first started to pass through our mental health system when she was 14, but as recently as last weekend was again seeking emergency help from our system, has kindly agreed to share his experiences of the acute aspects of our mental health system. So David, it's a great pleasure to have you with us. I wonder if you wouldn't mind starting by just giving us a little bit of an idea of what it's like as a dad to take a 14-year-old daughter repeatedly over the next few years, in fact, back to our acute mental health system, to our emergency departments, and what that experience is like.
Thank you. Ian, can you hear me firstly?
We can, very loud and clear.
Okay, excellent. So, I mean, the short answer is very, very difficult and very disturbing, and it leaves one feeling quite desperate. So my daughter has had OCD since she was about 5 years old, and this has been going on for years and years. It got particularly bad probably towards the end of 2015, and I had to navigate the mental health system. She was with adolescent services and try to get her into hospital, and that was an incredibly difficult task. Trying to navigate all the procedures and the requirements, and eventually through sheer perseverance on my part and also a particular psychologist who was invested in it, we managed to find a bed for her at a unit, and she was admitted there for a number of weeks, and that did her the world of good. But in the time since then, she's had ups and downs, and various periods during which she's been okay, and then various periods during which it's gotten worse. And we've had countless trips, I honestly don't know how many, to the emergency department. The way her OCD manifests itself is that she will have a panic attack. She will start to scream desperately. thrash around on the floor, smash things, you know, very extreme behavior. And obviously it's very disturbing at home. She's got a younger sister. It's very disturbing for us at home. And we've had police and ambulance here multiple times. She's been taken to the emergency department many, or probably most of those times under the Mental Health Act, the schedule of the Mental Health Act, because she was deemed to be at risk of serious harm. And then through the normal process, she goes to the ED, waits there about something between 8 and 10 hours before being seen by a registrar. And then at that stage, she may have calmed down, and then they don't deem her anymore to be at risk of serious harm. I was even told on one occasion that they couldn't take into account the report of the police that brought her in, because she has to be presenting as a serious harm right at that precise point in time. So it's been very, very difficult to get her admitted. So usually it's like a revolving door. We get sent back home again. She was admitted last year on 2 occasions to an adolescent unit. The first time for 3 weeks, and that did her a lot of good, but there was no real follow-up. And then she was admitted a second time, but then decided to leave after 5 days because she felt that she felt that it wasn't helping. And of course, she wasn't being held against her will at that stage, and so she left. And then she was admitted a third time, and they discharged her because she was finding it too difficult to do the things that they wanted her to do, which was the very reason she got admitted in the first place. And then we've had, up until this very last weekend, multiple more visits to the emergency department. Now that she's turned 16, she's treated as an adult. And so she's been at the PEC unit, I think that stands for Psychiatric Emergency something or other, unit at 2 different hospitals. And on both occasions, she was either not admitted or discharged very quickly. On one of those occasions, she'd actually gone to the gap and threatened to jump. And 2 days later, they discharged her and said that she wasn't at risk of serious harm. I pressed them on the issue, and I was told that, yes, maybe she was at risk of serious harm, but they were an adult unit and therefore not suitable for her. But she's treated as an adult under the Mental Health Act, so we're in this void. She's 16 and treated like an adult, but they tell us that they're not suitable for her.
So, David, you were telling me earlier on about going to different hospitals, where in some hospitals, the lack of communication between the emergency department and even the adolescent services of that hospital. In other hospitals, you're told she's too young to actually go into the services of that hospital. You know, this kind of issue, and I think you did use the word, if you don't mind me saying so, the system appears to be broken. This lack of coordination between things, particularly for teenagers, particularly for young people. Sorry, you're a round peg. We don't have a square hole that you fit. You know, that frustration, can you just share with us a little bit of that frustration from a parent point of view when we fail to respond and then you, the family, are somehow supposed to sort it out?
Well, yes, this very last weekend, in fact, she was going through a difficult time and various things happened, and again, got taken by ambulance to the emergency department at a certain hospital, and then got not admitted, but taken to the PEC unit at that hospital, which is the Adult Psychiatric Emergency Section, as I understand it. And, you know, we had long discussions with them, and they said they could probably keep her in for a night, but then she'd have to go into the adult ward, which they said wasn't suitable because you've got adults, strangely enough, having all their own issues, which they didn't think it was suitable to expose her to because she's only 16. And then there was discussion. I raised the issue as to whether she couldn't be transferred to the adolescent unit at that particular hospital. And I was told that even if there were a bed available there, it would probably take 5 or 6 days for them to be able to do such a transfer. And I found that absolutely incredible because it's the same hospital. So we ended up coming home again. So I don't know if that answers your question.
Yes, I think, David, that pretty much summarises the level that we've reached in our systems. But I wonder if you could say there are many issues. We were discussing some that were legal earlier and practice issues. But if there's 1 or 2 highest priorities that you as a parent who is trying to negotiate on behalf of a distressed and disturbed young person would really put an emphasis on us to focus on, you know, is there 1 or 2 really highest priorities from your point of view?
I would say, well, probably indirectly, the highest priority would be resources, because the way I see it, from the paramedics through to the psychologists and the doctors, they all interpret the law very, very narrowly. So I understand that the Mental Health Act talks about risk of serious harm, but what they take that to mean is a risk of imminent actions towards suicide. So I've actually been told in so many words that cutting oneself doesn't make the grade. So why are they not taking in people who are clearly at risk of serious harm? So maybe that's because they don't have the resources and the bedding. So I've been told that, you know, on numerous occasions that there weren't beds available, and that, you know, that would make it very difficult. So I would say probably the first thing is a combination between having enough resources, but also having a more appropriate interpretation of the actual law, rather than it being so narrowly interpreted. Because I mean, she's really suffering, and we as a family are really finding it profoundly difficult. Just to say, she hasn't actually been to school for about a year now, essentially, has spent the last 10 or so weeks lying in her bed, sleeping through the day, waking up at night for a few hours, and then going back to sleep again. So she's been completely disengaged with society. I mean, I would have thought that that is serious harm to a 16-year-old, but it's not treated as such.
Okay, David, I want to come back to you at the end after you hear what we've talked about to see whether you think we're at all on the right track or not. Now, at this point, I want to move to Professor Joanne Atkinson, who has been leading our modelling work as to what the situation was, Joe, in much of rural and regional Australia, and what's been the basis of our national model pre-COVID, and what we might expect actually as the COVID crisis, particularly economically and socially, actually plays out.
Thank you. Sorry.
You've muted yourself again, Joe.
Sorry. Is that better? Can you hear me?
Yes, we can.
Sorry. Thank you, David, for sharing that story. It really kind of is consistent with some of the lived experience perspectives we were getting when we were doing this participatory modelling project, and it really helps ground some of the work that we've been doing. So, so last year, our team, in partnership with North Coast Primary Health Network and with over 50 local stakeholders, collaboratively built a systems model for the region. Next slide, please. And modelling is such a ubiquitous term, and there's been some misunderstanding about this type of modelling. So I'll just briefly introduce the basic architecture of system dynamics modelling. So there are stocks, which are quantities, and in this case, the stock is a population, and there are flows, which are the arrows, which are rates of inflow and outflow from the stock. So in this simple example, the population changes over time depending on what's being added to the population through births and migration, and what's being subtracted from the population. So just like a bathtub whose water level rises if the quantity of water flowing in from the tap is greater than what's escaping from the drain, and vice versa. Next slide, please. So from these very simple building blocks, we can represent health systems and social systems, and the flows of people through them, and the factors that influence those flows. And in this example of the mental health system, when we run the model, the proportion of the population waiting for services or receiving services is changing over time based on the different rates of flow into, within, and out of the service system. Next slide, please. So if we zoom out, this is a high-level overview of the causal structure and pathways of the North Coast model, and you can see that see the interconnections between the psychological distress component and the mental health services component, and the key social determinants of mental health. So when unemployment goes up, not only does it have a direct effect on the rates of high to very high levels of psychological distress, which has knock-on effects on the rates of substance misuse and adverse early life exposures and service demand, but it also affects the rates of domestic violence and the rates of homelessness, both of which further exacerbate levels of psychological distress and so on. And these are the feedback loops that drive the vicious cycles and the virtuous cycles that exist in the real world. And only through systems modelling can we really understand and explore how best to invest adequately to break these vicious cycles and reduce pressure on our mental health system and set us on a path of improved outcomes and healthy communities. Next slide, please. So this is just a slide that shows that the model is able to reproduce historic data across a range of indicators so that we can have good confidence in its forward projections. Next slide, please. So this is the interactive interface of the model that facilitates scenario testing. And at the last webinar, I focused on forecasts for suicides in the region, but we're going to see also going to see increased pressure on our health systems through mental health related ED presentations and self-harm hospitalisations. And under the pre-COVID scenario, mental health related ED presentations and self-harm hospitalisations per year were already rising and forecast to rise further before plateauing in 2021-2022, with an estimated 42,700 ED presentations and 6,300 self-harm hospitalisations projected between 2020 and 2025 in the North Coast region alone. Next slide, please. So we then ran a scenario that mimics the social and economic impacts of the pandemic and subsequent recession, with the assumption of a peak total unemployment rate for the region of 11.1%, which is the red line, and a peak youth unemployment rate of 24%, which is the orange line, and a pattern of unemployment that you can see in the graph, with the peak occurring later this year and then declining thereafter. And we also assumed a 10% reduction in social connectedness as a result of lockdown and also the isolating effects of unemployment. Next slide, please. So under this set of assumptions, the model forecasts an increase in the prevalence of high to very high levels of psychological distress in the community that doesn't return to pre-COVID levels within the next 10 years. Next slide, please. We're also likely to see a 15% increase in mental health related ED presentations over the next 5 years. That's an additional 6,500 ED presentations for the region. Next slide, please. We're also likely to see a 20% increase in self-harm hospitalisations in the region over the next 5 years, which is over 1,200 additional people attempting to take their own lives. But it doesn't have to become a reality. We can use this model to test strategies that will help us realise a different future. In the same way we use this kind of modelling to avert the full impact of the COVID-19 pandemic in this country. So what will it take to bend this curve? Next slide, please. So when we simulated a 20% increase in the current growth rate of the community-based specialist mental health services, it resulted in only a 0.8% reduction in mental health related ED presentations from 2020 to 2025. However, the impacts do increase over the longer time horizon that's shown in the graph. Next slide, please. It also results in only a 0.4% reduction in self-harm hospitalisations over the next 5 years. Next slide. If we increase the growth rate in community-based specialist mental health services by 50%, this results in a 2% reduction in ED presentations over the 5-year period, but over the 10-year time horizon, it brings ED presentations almost back down to pre-COVID baseline levels. Next slide. But it only results in a 1% reduction in self-harm hospitalisations over the next 5 years. Next slide. It's not until we double the services capacity growth rate that we see a more effective bending of the curve, with a 4% reduction in ED presentations. Next slide. But this still only reduces self-harm hospitalisations by 2%. Next slide. If we supplement services capacity growth with improved care coordination enabled through digital technologies, it more than doubles the impact of services capacity growth alone, producing an 8.5% reduction in ED presentations and taking us to below pre-COVID baseline levels within the next few years. Next slide. It also more than doubles the impact of services capacity growth on self-harm hospitalisations, producing almost 5% reduction over the next 5 years. Next slide. And if we add to that combination post-suicide attempt assertive aftercare, it has little impact on ED presentations, next slide, but it does have a significant impact on self-harm hospitalisations, delivering an 8.8% reduction over the next 5 years. So these strategies to try and help flatten the curve could further be supplemented by initiatives that are not currently included in this model, but the model can be expanded to in the future to be able to test a broader range of initiatives. And I'll just end by emphasising that the timing and combination of strategies to bend this curve are important and should be tested in the safe environment of a systems model model before being implemented in the real world. Thanks.
Joe, that's marvellous. Professor Mendoza, who's joined us, says, are the people responsible for our systems yet alarmed? I'm alarmed. I mean, and anyone as a parent as I am, and Liz and I are, of teenagers and of young people in these kind of settings who don't understand the scale of what we're talking about. And I think a point you're making, and I think David's own experience, including last weekend, it's a system under pressure already. And that pressure, of course, led to the referral of the mental health system to the Productivity Commission by the previous government, from the Turnbull government period, when the current Prime Minister was the Treasurer, and they are due to report on June 30th this year. Concurrently, we have a Royal Commission running in Victoria, and I want to invite Professor Joe Robinson now to speak about the work that Origin has led, and we have had Professor Nagori join us, and we'll get to some other innovations here. But Joe, I suppose the reality is that Victoria, with its Royal Commission, its state services, is probably the state at the moment that is struggling most to really come to terms with this, how to organise itself, what will happen. And a big driver of that was a recognition of emergency department pressures and acute presentations. You've been working, and we'll come to Simon Junket shortly, with emergency departments on protocols, on approaches, particularly around young people in these areas. So I wonder if you could share us with some of the experiences of what's driving that work in Victoria and where some of the ways forward might be that the Victorian government is now considering funding at scale.
Yeah, absolutely. Thanks, Ian, and good evening, everybody. So I'll talk a little bit about some of the work that we are doing in Victoria and what we're hoping that that will achieve, and also kind of ultimately that, you know, we're hoping that it will lead to improved experiences. So David and other people like him and his family don't have to experience what he's been experiencing. So we're doing a big piece of work partnering with a number of emergency departments across Victoria to really understand, you know, who's presenting to emergency departments with self-harm, what are they presenting with, what sort of treatment they get, and how that we might work with EDs to start to improve practice. So what you can sort of see here on the slide is that we're starting to develop a self-harm surveillance system and work towards best practice models here in Victoria. So we're doing that by sort of aiming to really understand the epidemiology and the frequency of self-harm presentations, but not just by young people. We're very interested in young people, but we're actually doing this across the age range. So what do those presentations look like for self-harm in Victoria? Partly to understand them in and of their own right, but also to develop perhaps a lead indicator towards how we're doing in terms of tracking towards reducing suicide rates as well across the state. We're looking at what the gaps might be, partly in terms of data collection, but also really in terms of patient care. And then we're trying to understand what some of the barriers are to delivering optimal care that, you know, we've heard David talk about already, but what are some of those barriers from the perspectives of staff, young people and their families? And ultimately, as I said, what we're hoping to do is improve outcomes for young people, improve data collection, but also maybe work towards a real-time response so that when we are seeing increases in particular types of presentation to hospitals, we're actually able to provide a community level response in the real time. So if we could just have the next slide, thanks. So what are the benefits of self-harm surveillance systems? So there are a number of existing self-harm surveillance systems around the world. Probably the longest standing one is based in England. And we do have one here in Australia, but at the moment it operates in Hunter, New England area in New South Wales, but only really looks at self-poisoning presentations and intentional overdose. So it doesn't really span the whole range of problems or methods of self-harm that people have used that we'd like to better understand, I guess. So there are a number of surveillance systems that exist in the world, and they have led to all sorts of useful things, I guess. So they've led to improvements in practice and policy and in the areas where they exist. They've been able to guide evidence-based practice and policy. They've been able to guide the development of those protocols, Ian, that I know you referred to earlier. They've been able to really guide what appropriate resourcing might look like. So, for example, we know that a lot of the presentations by young people to ED happen at night. And when EDs are perhaps not well resourced with mental health staff. So we can really guide when we might need better, or more resourcing in terms of staffing, etc. And they've been able to kind of lead to improvements in the quality of assessments and treatment that young people receive when they do present. They also have lots of kind of research benefits as well. So, you know, I'm a researcher and we're very interested in things like the epidemiology around self-harm, what the rates are of self-harm, what the rates of repetition are like, what's the relationship with subsequent mortality. So, for example, by suicide, what types of methods of self-harm are people presenting with. But probably more importantly, they allow us to then evaluate these sorts of systems, allow us to evaluate the impact of those practice and policy initiatives. So we know that, you know, if we're spending a lot of money and resourcing, and, you know, fortunately we are, you know, we've got a lot of attention being turned to this here in Victoria. But how do we know that what we're doing or with what we're spending money on is the right thing? How do we know it's impacting on outcomes, better outcomes for young people? So these sorts of systems allow us to evaluate those much more easily. And they also allow us to evaluate or to assess the impact of major events, for example, like pandemics. So we get asked a lot, what's happening in emergency departments now in the context of COVID-19? Are we seeing increased or decreased presentations? And these sorts of systems will be able to answer those questions. So if we could have the next slide, thanks. So what we're doing is we've got 8 study sites across Victoria. We're working with 6 metro sites and 2 regional sites. And at the moment, we're getting data from those sites quarterly. We apply some text mining and machine learning algorithms to the data that we receive in order to identify who are the self-harm presentations. And then we cross-check that with case auditing, file auditing protocols in order to make sure we're not missing the wrong people and, you know, we're not counting the wrong people, basically. Next slide, thanks. So that's kind of what we're doing in terms of kind of setting up a surveillance system, which we hope will speak to other systems across the country and really will be able to move towards really strong, robust data on self-harm presentations. But we also hope it will lead to improvements in practice. So we've been working with staff in the emergency departments and talking to young people, and you can see a couple of quotes from the young people up on the side of the slide there. But really what these sorts of, what this work is telling us is that what we need to be moving towards is better education and training for our staff. And we are doing some of that work with emergency departments at the moment. But people are really crying out for youth-friendly settings, really clear protocol management when young people with self-harm present to EDs with self-harm, in the same way that we have protocols in place when people present with chest pain. We need those same sort of protocols for people when they present with self-harm. We really need to be moving towards collaborative and psychosocial assessment and ongoing safety planning with people when they present, and then streamlined and fast-track referrals into appropriate systems of care, depending on what the needs and wants are of the people who are presenting. And part of that is what Joe alluded to earlier, which is around assertive aftercare. And again, we know that the Victorian government is investing in that going forward as one of the outcomes from the Royal Commission. But those sorts of systems need to be youth-friendly, they need to be based on best practice, and they need blended models of care where we've got clinicians working with peer workers, we've got face-to-face, and we've got digital interventions working together. And as I said, you can see some of the quotes up here, and one of them really speaks to the point I think that David was making earlier, whereas it wasn't enough for a young person to express that they felt at risk. They had to really be seen to be being at risk before they could get treatment. And we've had young people say, you know, how suicidal do I need to be before getting the treatment that I'm asking for? But on a more positive note, the other quote talks about some of the positive experiences and what young people were able to reflect in terms of what worked well. And some of that shouldn't be difficult to resource. It was really some of those softer skills that we know are so important in terms of, you know, listening and paying attention and really appearing to care, taking a holistic approach to understanding what was going on for the young person, not diving straight into what we might refer to as a risk assessment. And next slide, thanks. So in terms of some of our next steps, we've got Dr. Kat Witt working with us, who's recently been awarded an NHMRC grant to do some work that will also be working alongside the CRE that we've got together with Brain and Mind Centre. And together we'll be developing some data linkage systems to really establish and understand individual treatment pathways following an episode of self-harm. So what happens next, linking up the ED data with other sources of data. We'll be looking at the effectiveness of different treatment pathways or interventions on rates of self-harm, repetition and suicide via a suite of kind of clinical trials and using the modelling that Joe's just spoken about. And then really looking at developing some alternative health pathways and treatments that are fully informed by evidence. And we'll be very much working in partnership with people with lived experience as we do that work. The next slide. So just to bring all of that together, really, I think the current pandemic has really highlighted the potential value of real-time monitoring when it comes to health. Imagine if we hadn't had the real-time data collection that we've been lucky enough to have around our physical health. And what we're working towards is having some of that real-time monitoring for self-harm and suicide risk as well. We need to explore novel and linked data sources for suicide and self-harm surveillance. So looking at expanding, for example, some of the state-based suicide registers, how we can make those more accessible and more timely, so we can use that data in a really meaningful way in real time. And there is some work going on around that currently at national level here in Australia. And we'll be very excited to see that kind of scaled up. But we need those things to be linked to the testing and implementation of best practice protocols and treatment if we're really going to make a change to people's experiences when they do present. And I will leave it there. Thank you.
Thank you so much, Joe. And you've just introduced a very important part of what we do, which is the National Health and Mental Research Council's Centre for Research Excellence that we have for youth suicide prevention. And it focuses on these pathways to care. And a very important member of that team is Dr. Simon Judkins, who's the immediate past president of the Australian College of Emergency Medicine. And during his presidency, to our great benefit, he led a very important national movement to the recognition of the importance of mental health within emergency departments and emergency room physicians being at the front of this particular drive. Simon, I really want to know, I'm a middle-aged man. I go to emergency departments not infrequently with a certain kind of heart problem. And there's a protocol, there's a place. I know I'm not going anywhere until I'm well assessed, until I'm safe, until I'm connected with good care, because there are protocols, there are standards, there are issues in place. Can we ever hope to achieve that same kind of standard of expectation of care for mental health presentations, for self-harm, and I guess particularly we've focused on presentations in young people?
Yeah, thanks, Ian, and thanks for inviting me to come and participate today. So I suppose I just want to give you a bit of an idea about, what's been happening with mental health presentations in the emergency departments across Australia, where we are currently, and I suppose the importance of the work we're talking about now, because after listening to the first couple of presentations and having just finished the day working in a busy emergency department, my heart rate has immediately jumped up to about 140 beats a minute, just because there is a heightened sense of stress within the system now, which is just going to get, I think, even more and more stressed unless we get some fairly urgent actions on some of the initiatives that we've been talking about. So we know that looking at mental health presentations across the system for the last 10 years have been going up and up and in every state and jurisdiction, and they're increasing faster than our general presentation. So you can see that there's been growth year on year, about 3% of presentations across EDs, but mental health presentations are growing faster. And in fact, if you look at it on a per capita basis over the last, there's been almost a 60% increase in presentations on a per capita basis over the last 5 to 10 years with people coming to EDs with their mental health presentation. So it's certainly putting the system under a lot of stress. So next slide, please. And so looking at the demographic data in a bit more detail, you can see there about a third of the presentations are 18 to 34, so a large cohort of patients presenting in that age bracket. I haven't looked at the adolescent data there, but certainly we're seeing an increase in adolescent presentations in EDs also. About 50-50 male and female. We're seeing a significant proportion of Aboriginal and Torres Strait Islander presentations, disproportionate to obviously the general population. Obviously there's an issue about socioeconomics, the lower two socioeconomic quartiles presenting being half of the presentations. Although a large number, 66% of the presentations are in major cities, we see that EDs, particularly in regional rural areas, are really a focus for mental health presentations. Unfortunately, in those areas, as we know, the resources available for mental health care in regional rural areas is significant. And this is where we're really seeing some of the issues around patients spending long times in EDs waiting for transfers. I was recently working up in a regional area where we had an adolescent waiting for a mental health bed who waited 3 days in the emergency department for a bed. So, you know, coming in with mental health disorders, self-harm, and spent 3 days waiting to be transferred to an inpatient unit. So, which is obviously clearly, and as we've heard from David, that's clearly damaging to that poor young lady. Next slide, please. So the experience of patients coming to EDs, they're more likely to arrive with police and correctional vehicles, more likely to arrive by ambulance, less likely to be seen in the time, and that goes back to the point you were making, Ian, that we don't have clear pathways. We have protocols for acute myocardial infarctions, we have stroke protocols, we have toxicology protocols, but you know, our protocols for mental health presentations clearly aren't as robust as those other physical conditions. Patients are more likely to wait longer. They're more likely to stay for 24 hours. And if you look at 24-hour stays in emergency departments across the country, which are increasing despite our advocacy, they're almost purely patients waiting for mental health care and mental health beds. So that problem is growing and growing, and sadly, more likely to leave at their own risk without a definitive care plan, without actually getting a proper mental health assessment, and clearly without appropriate outpatient or community-based follow-up. Next slide, please. And you can see they're just emphasising the issues around the wait. We're working in a system that is overcrowded, that is increasingly stressed, that doesn't actually have the capacity to be able to absorb the workload that continues to present there. And once a patient is deemed to be, you know, need admission into a mental health bed, you can see that they stay an incredibly long time for that. If you compare mental health presentations or admissions to other admissions, 90% of our admissions to hospital wards for non-mental health presentations get admitted within about 11 hours. For mental health patients, you can see that blows out to almost 18 hours. And as I said before, almost exclusively patients staying longer than 24 hours in emergency departments and mental health presentations. And we've heard stories from across the country of patients, as I said before, staying 3, 4 and 5 days in emergency departments waiting for inpatient beds. So clearly it is a system that is fractured and a system that just doesn't have the capacity to absorb the workload that's presenting through our ED doors. Next slide, please. So again, we realised that within the emergency departments, there was a lot of work that we need to do. The emergency department clearly is a very difficult environment for patients. And as we know, and as David has said as well, it's clearly not a therapeutic environment. So unfortunately, it seems to be in our current environment that all roads lead to the ED. But we also recognise that the ED is not a very therapeutic environment for patients. And that data that we've just presented really sort of supports that. So it's certainly it's an appropriate environment for somebody who comes in with a crisis, because it's certainly not we don't have the infrastructure to be able to support people in a quiet and as I said, a therapeutic environment. There are extremely long waits, but unfortunately most people who do come with a sense of trepidation because they've really got nowhere else to go. Next slide, please. So the reasons for this, and I think we've alluded to some of that already, that there's a lack of crisis services available 24 hours a day. There are insufficient mental health beds, so when patients do need an admission, and ideally, obviously what we would like to be able to do is make sure that people don't need to be admitted and where they're able to access the care that they need within the communities, but there are just insufficient mental health beds in the way our current system works. And that means that patients are not only having long delays to admission, but they're probably getting discharged out the other end because of the pressure on the front end. And I've often heard managers of mental health units saying they just feel like risk managers. They're trying to get the risky patient who's in the ED in, and they're sending the less risky patient who might have had a 1 or 2 or 3 day stay back out into the community without that link back into the community for their ongoing care. As I said, clearly there's inadequate capacity in the community, and also we need to ensure we further enhance or support primary care for mental health. Next slide, please. So our goals from an emergency department perspective is really sort of be an advocate for the system to ensure that when patients do need to come to EDs, that we actually have a therapeutic environment that we can offer them and make sure that they are welcomed, they are looked after, they are treated in an appropriate environment and not in the daily hustle and bustle of a high volume, stressed emergency department. Next slide, please. So the way we want to do that is obviously we want to create some standards in our emergency departments, working with other partners within the system, and that's about improving standard of care in the emergency department. And again, David alluded to that, but that will be looking at ensuring that we do have pathways and processes, Ian, as you said, that look at really giving us guidelines about getting patients through their system effectively, getting them to the right patient at the right place at the right time. Having peer workers, for example, working in emergency departments, having time bases, expectations of length of stay in emergency department. We're looking at implementing alternative models of care, which includes things like mental health hubs within EDs, and just rebuilding our infrastructure, because it's certainly not a one, EDs are very much a one-size-fits-all environment, and we need to recognise the particular needs of different patient groups, ensuring that we have increased availability of crisis services within the community, and also ensuring that people know how to navigate the system. And I think we've made that point a number of times that, people and their families, patients, their families, people with mental health crises, the system is very hard to navigate. We've had plenty of examples of patients trying as hard as they can to get the right place, but either the appointment is in 3 weeks' time, it's across the other side of town and they don't have a car to get there, or they just simply can't afford it. So unfortunately, all roads end up leading to the ED. Thank you.
Thank you so much, Simon. And you've highlighted, the pressure in emergency departments. And for those who don't know, I've had the pleasure of ringing Simon on a Sunday morning where he stepped out from a cardiac arrest to talk to me, and fortunately gone back and helped with the cardiac arrest. He's at the front line of these issues. And his leadership in the area of emergency departments has been one of the drivers. But the emergency department is that last resort. And we're not saying it's the optimal resort. Clearly a system change, as Joe Atkinson was emphasised, required to relieve pressures. Now, the next two speakers, John Mendoza and Pat McGorry, are both looking at ways of trying to find alternative models to these emergency rooms being the only last resort that is active in acute care settings. So John has recently moved from the warm climes of Queensland, the COVID-free warm climes of Queensland, to South Australia to take on these sets of problems right in the middle of what we'd call the emergency room crisis in Royal Adelaide Hospital and the Central Adelaide Local Health Network. So John, having gone to Adelaide to really the heart of one of these crises, a brand new hospital that actually doesn't necessarily have the functional capacity, and looking at real alternatives, what are your views?
Thank you, Ian, and hello to everyone. Nice to be with such august company tonight. Well, look, I'm still getting used to the temperature in the Southern Ocean, I've got to say, but it's a challenge coming from the Coral Sea. I wanted to just sort of come out from where Simon was looking at the data. We know things are challenging, but I would say that the variance in ED performance across Australia is rather striking. And even here in Adelaide, I can look south at Flinders Medical Centre and north at Lyell McEwen, which I had a bit to do with in trying to set up an alternative pathway in that area a few years ago, and can see vastly different performances. And one would argue that the northern suburbs of Adelaide, with the loss of the car industry and manufacturing virtually gone, faces much greater social determinant pressures driving people to ED than here in central Adelaide, although we have a very large disadvantaged population to the west of the city as well. A couple of things I wanted to start with. I just tried to pull a slide out of a report that I did for the executive and board here in Adelaide last year. And it really looked at globally, what are the key strategic approaches? Because this is not just an Australian problem. This is a very big issue in the United States. And over an 18-month period, I was part of what we might call a community of practice with 11 leading organisations in the US, including a cluster of 11 hospitals in the South Sacramento Valley, which work very collaboratively together, and Kaiser Permanente really is the the backbone organisation that's supporting that group, working with UCLA Davis Medical Centre. And looking at those models, looking at the best practices here in Australia in places like the Alfred in Melbourne, St Vincent's in Sydney, Charles Gardner in Perth, we can see that there are a number of approaches that hospitals are using to try and respond to this challenge in this surge in presentations of people in crisis. And these crisis presentations are not a greater number of psychoses. There are some drug-related psychoses that come and go, but these are people that are driven by their circumstances to end up at an ED because their lives are falling apart and they are in the biggest crisis of their life and they don't know where to go, and their friends or family or police or AMBO bring them to the ED. And as Simon said, it's not a particularly attractive or compassionate therapeutic environment when you are experiencing that sort of crisis. So they're the four categories, but what I'd say is that the sort of core of it is where we're seeing success in this space in stemming this demand and managing in a more compassionate, therapeutic way is that we shape demand. We try to use a number of levers to shape the demand that presents at the door. So we work on root causes in coalitions, in collaborations, those sorts of things, to work as far upstream as we can to influence the drivers of despair. We then have to focus on how do we match the resources that we have available. In any health system, there's a cap on how much resource we have. And how do we match that resource to the demand? So we've got to apply the models of queuing theory, of scarcity, of flow, to really do that as effectively as we can. And these are not commonly understood principles and approaches in our healthcare system. People simply want to continue to ask for more or continue to do the same practices. I do not see a lot of innovation other than those few hospitals that I mentioned around the country in the way that we're responding to this. We continue to apply the same sort of consultant liaison psychiatry into ED. It's a failed model. It belongs in the the memory box from last century. I do not see the innovation in the infrastructure that we see in the US and elsewhere in Australia yet. We still build large multi-cubicle EDs that are fit for people with strokes, with heart conditions, other stomach problems or whatever, but they're not built for people with psychological problems. So we've got to match the capacity to the demand. We've got to match the settings, the infrastructure to the demand, and we've got to match the philosophy of care. We must change these things if we're going to see different outcomes. Where we're going in Adelaide, and I'd have to say that in central Adelaide, serving a population of about 500,000, in this city, Carlin represents about 40% of the state mental health capacity. So we do a lot of services for the regions as well. But essentially what I'm trying to build and work towards, which the board endorsed as a high level principle in a sense, is understanding that we've got to build an ecosystem of care, that we transition people through this system to the most appropriate setting for care. Now, at the moment, if you appear at the Royal Adelaide or any other acute hospital in Australia, there's more than a 50% chance you'll be discharged to nothing. Nothing. You won't have a discharge plan. You won't have any connection or handover, warm handover. You just make your own way with your family back to whatever you distress. And David's story was illustrative of that earlier on. And this is an incredibly common experience everywhere around the country. The second thing is when you're discharged from the inpatient unit, the follow-up care you get is lousy. It's highly variable. And we know the evidence is overwhelming that the first 7 days, in fact, the evidence in Queensland is very clear. It's the first 3 days after that discharge from inpatient care, you're in a very, very high level of risk. The highest level we know is in that period. And yet we still can't connect care to that group of people. This ecosystem really describes a different way of responding, and no one is discharged to nothing. Everybody transitions to care. And that has to be a founding principle, a philosophy that we adopt. And so this shows a system where we have collaborative governance with shared metrics. We're all trying to achieve the same thing as a group of entities, organisations trying to provide continuous wraparound care for people in crisis. If we go to the next slide. This is then an example of this taking one particular service innovation. And what I see consistently around Australia in responding to the challenge of this surge in crisis presentations is we see some sort of a bolt-on. We see a cafe bolted on, or we see some other thing that's bolted on after, you know, the silly Wayback program, high cost, low impact sort of program. These will not work. You've got to have this philosophy of a systems approach and use data to drive the thinking around it. So we're looking at an urgent care centre within walking distance of the Royal Adelaide, and it's built on this same flow and consistency approach. So if you enter this centre, you will be connected to something. We'll use smart technology. In the Interwell platform will form a core feature of this, and with peer workers chaperoning the person throughout the care journey to the most appropriate setting. And you can see where the people are coming from to the urgent care centre. Linkages are with the street interventions, what I call street interventions. That's the SAPOL, that's the police, the SAS, the ambulance, the mental health triage, the mental health crisis teams in the community. They're the street interventions where we're trying to, again, keep the person away from, if you like, or keep them in the community as best we can and wrap the care around them in that setting. GP liaison is another service that we're providing into that space very shortly. And you can see that all of this is underpinned by digital integration, by data and shared decision-making and collaborative governance. We can move on, please, to the next slide. So this urgent care centre, that's the patient flow. It's a concierge, 2 minutes. You appear, you're seen within 2 minutes. You're offered a digital assessment, a comprehensive digital assessment. Or if you don't want to do that, a face-to-face assessment with a peer specialist. There's no clinician within sight, and certainly no security within sight within this centre. You can continue with the peer specialist.
Can you just emphasise that? People have raised this in the Q&As and constantly with us. You are going to use peer specialists to support these assessment processes.
From the get-go, Ian. So the chaperone is the peer specialist throughout the journey on the left side of that slide, the peer stream. The clinicians come into the stream, the allied health, the social workers, the nurses, they come into it to support that peer worker in the work that they're doing with that client. And that client might be in this centre for 4-6 hours, and then they're moved to another place, another setting, another service. If they need an acute admission, then that's fast track. They bypass ED. There's no going to ED again after you've been through this. And we will have patient transport that's appropriate for them. No alarms and bells and whistles going off that further traumatise people. A point that I'd take from what Simon said before as well, he said, you know, the vast majority, I forget the percentage you had there, Simon, but there's a very significant number of people in that under 34 age group presenting in crisis. Now, we're traumatising these people. We're diminishing the opportunity for them to engage with services in the long term. We're failing them at the very first hurdle. We've got to overcome this. We've got to be a welcoming and inviting, a positive experience from the word go. Muted myself. Next slide, please, Grace. So the digital platform is a part of this, but it's not the solution. It's going to be underpinned by a continual modelling and data collection that informs the way we refine the systems within this. So the way this will inform how we change the co-responder models that are located with the police and the ambulance, the way we deploy the GP liaison into the community. All of these will be informed and tweaked so that they integrate and work together, not as separate entities. This is the failing that I see around the country. We continually go to a program response. We don't think systems. And lastly, We'll be running a course soon on system design.
Yes, John, I think we'll take that for what it is. Just if anyone didn't catch that in relation to the Interwell platform, I have a conflict of interest to declare in relation to the Interwell platform, as it's a spin-off of the University of Sydney and PwC, in which I have a small equity shareholding. But John is bringing the issue about we've modelled elsewhere of IT collaborative systems, of which there are many, sharing information, guiding things through pathways. Clearly, John, in a most challenging situation which has been created by the birth of Royal Adelaide Hospital and the concentration, you're attempting to provide realistic alternatives, fast admissions for those who need admissions, alternative pathways, not relying on everyone having to go through the ED particular setting, and the inclusion, Pat McGorry can address this in a moment, the inclusion of peer workers as part of the journey, not instead of clinicians, alongside of clinicians, as part of the journey.
Correct.
Just for everyone's notice.
The key thing, Ian, is it's about setting up alternatives. This is about how we shape demand. Not all roads lead to Rome. Or the Royal Adelaide in this case. We've got to create other pathways.
I've never thought of Adelaide as Rome, but I'll keep that in my head from now on. Just for those who join us, we were planning to finish at 7:30, and there are a number of other important perspectives. So if you stick with us, we will continue a little bit longer. And second last, but not least, Professor Pat McGorry has joined us. And I know he's been very busy on the case of the Treasurer and other people this evening about investments in mental health. But Pat, I don't know that everyone knows. You're so world famous for early intervention. I don't know that everyone knows that you really started down that line to reduce the trauma associated with hospitalisation, particularly of young people, and the trauma that John and others have just mentioned of their ongoing experiences in emergency departments. And now you've been at the forefront of advocating for alternative hub-like models for specialised mental health care in the community. And you're tied up very much with the advocacy and the modelling of that, the developments and models of that for the moment. So can you tell us your thinking about, picking up from John, developing real alternatives to just having everyone who needs more specialised assessment turn up in an emergency department?
Yeah, okay, thanks, Ian. Do you want to unshare the screen? You probably don't need the help. I'm not using slides, so I can just talk here. So thanks for the opportunity to be part of this too. Pretty much the first paper I wrote in psychiatry was based on a study we did of a whole cohort of young people coming into the psychiatric hospital system for their first experience of care. A bit like what John was actually saying, that the most obvious thing was that we were making them worse before we made them better. And we were able to sort of assess them, follow them up, and we found that this was based on a clinical observation of a patient that I saw in a clinic probably a few weeks or a few months after they had been admitted for the first time. And they were having PTSD symptoms about their experience of treatment. It was a combination of the terrifying nature of the psychosis they had had, but also the fact that they'd been forcibly sedated, handcuffed by the police and thrown into a seclusion room. So they were actually having nightmares and intrusive memories of these experiences. So we measured that, and we found that 45% of these first episode patients actually experienced those problems. And that is happening to this very day. When people get shackled in emergency departments, when they get forcibly sedated, and probably the folks are shifted from the psychiatric unit to the actual emergency department these days. So with these large numbers of security guards surrounding them and intimidating them and all sorts of other things that happen to them. So I couldn't agree more with Simon that it's the wrong place for looking after people. So all the efforts that you've been talking about tonight to prevent that from happening and making that an absolute last resort are great. And what worries me a little bit about John's presentation is that it's still assuming that you have to be in the hospital, in the big, palace of the hospital to actually start, pushing things upstream. So what we think should happen is actually addressing this concept of the missing middle, which has been very carefully mapped over the last few years. And it basically is an obvious thing that, we've actually built systems of care that are doing better, still not perfect, about providing primary care access. So the first port of call is more accessible than it was, say, 20, 30 years ago. Still, obviously, could be critiqued and not perfect. And the state governments have actually continued to do the super acute bit in a rapidly shrinking way, so much so that we've now got a Royal Commission Victoria that you referred to, Premier describing the system as broken. So States have actually retreated, if anything, from their responsibilities. So there's a huge hole, there's a huge moat in between. And because there's nothing there for the more complex or persistent or more challenging sort of problems, comorbid problems, they all end up, as people are saying, in the emergency department, and only when they've actually reached a point of crisis. So there's a whole lot of untreated morbidity out there that hasn't reached the point of crisis yet, just sitting there like a big sink of misery and distress and suffering. So what do we need to do? We need to build something in that middle. And what should it look like? And, you know, take the point that, you know, is there any genuine real reform in that? I mean, some of the things that we are trying to advocate for are really reprises of the 1990s, you know, the mobile and assertive treatment sort of functions and those sorts of things. So technology is obviously the main difference from those days, and that obviously can augment and strengthen in the ways that Joanne showed in your modelling, and really improve the power and capacity. But we obviously need a very substantial growth in resources. Now, we're not going to do anything by, you know, appointing more coordinators and more peer workers to coordinate nothing. You know, I'm sorry. I think that's without a significant surge of investment. That's sort of what the government is saying at the moment. All we need is more coordinators. We don't need more coordinators. We need more people to actually do the actual work and it's complex work. And we need teams of people. We don't need individual providers doing that. So what is the way to do that? Well, a focal point in the community. This is what we advocated for before the 2019 budget. And the federal government have endorsed a version of this. And this is in the youth area, we could expand and we could build on the base we already have, which is the enhanced primary care model of Headspace. We could build more back-ending of that, and we could enhance it with digital technologies, as you've all been saying. But in the adult area, we have this problem. You know, the GPs see the people. They can't get any next step. They can't get the next stage of care. I'm not going to say step care. You'll be pleased to hear. I'm saying stage care. So the next stage is missing. The next 2 or 3 stages are missing. So can you collapse those into a more specialized, multimodal, holistic sort of model, including peer works, including volunteers? That's another thing I've seen in Europe. You know, large bodies of volunteers, not paid peer workers, but young people in service actually really wanting to help and playing a role. So that's another untapped and reasonable resource to actually look at. So, but we also need addiction specialists. We need psychiatrists. We need psychiatrists to stop practicing in isolated private practice mode and actually be part of teams. There needs to be incentivization of that. We need you know, quite a range of disciplines in these community focal points, and probably the right size of population is roughly equivalent to a federal electorate, I would say. Surprisingly enough, that might be quite powerful in actually getting the thing funded. So, you know, there is federal government commitment to 8 of these concepts. Now, it's still not clear whether the concept is going to be right. You know, there's been a technical advisory group working on that, and I think it's got it in some kind of shape, but there's a public consultation about to happen on that product. Can't really comment on it until it comes out publicly, but you know, the sector and the general public and the consumers will get a chance to comment on what they think of that. I think there's a way to go before it gets to something really useful. But if something like that was well funded and dragged in other funding streams like MBS, NDIS, and a whole range of other sort of maybe state government resources too, you could actually see a way forward for something to sit behind the primary care structure, more accessible in the community, more trusted, less stigmatized, with a positive brand, a welcoming brand, picking up what John was saying about the welcoming and you know, the trust issue. That could be there, and then that could, if something like that was like a sponge there to absorb that demand, then you could see a lot less traffic going to the ED, and also it could be a destination back from the ED, a bit like what John was just saying. So there's a few missing structures, and they can be also augmented by a number of connections now with telehealth and with digital health, which wouldn't have been possible back in the 1990s. But people are still important, and actually skills and specializations are important too. So, you know, I think doctors do have a role to play. And I think John should put a psychiatrist or 2 into his model, not just have peer workers and allied health. So
I think we all got the point. We need all.
Pat,
Just before you
Pat, it does have telepsychiatry backup, so you just
Okay.
not enough money in the model to make it stretch to having them on site, and I would argue they're not necessarily needed.
Okay, well, that's something.
Not in person, on telly.
These are ongoing issues. So I think on the positive side, the peer support, I think, is one aspect. The technology, these are new aspects that are expanding. I think what Pat's arguing about is, of course, in many of the ongoing complex situations, and I think in the models that we have, at the heart of most of the modeling we've done in this area and other areas, the role of more specialised care in ambulatory care settings. So if you ever enter the system, as David was discussing at the start, you get into effective ongoing care systems. Pat, I wanted to ask you about, and many people have asked you in the chat line, where you think the national advocacy is at. I mean, I've been accused of running around saying the sky's going to fall in and being alarmist and I am alarmed about Joe's modelling.
You're just a scaremonger. You're just a terrible scaremonger, and that's your trouble. But
Yeah.
no. Well, look, I just contrast. You know, I said to the Treasurer tonight in a private webinar, we've lost 103 people from COVID-19, thanks to the great efforts of the whole health system and the country and all the rest of it. In the same period of time, we've lost 1,000 people to suicide. So, you know, are we going to make the same effort in mental health that we have made in one health problem, which is life-threatening and potentially serious? We've done a good job there. What are the lives not of the same value? So I think it's a rhetorical question. I don't know the answer to it. I really don't know. I mean, they indicated that it's a high priority for the government, you know, that, but it's really does the money follow the rhetoric? Does the reform appetite follow the rhetoric? And these are things that you and I and John and everybody else probably connected to the call have struggled with for quite a long period of time.
So I think one of the things we're discussing tonight is, of course, for governments to act, problems have to be tractable. They have to see examples. So John's pursuing certain kinds of examples in relation to the public sector in Adelaide, the ones you were talking about, Pat, in the youth area, the things Joe Robinson was talking about earlier. One of the other ones that I've been particularly keen about is I was struck in the COVID-19, the extent to which the health minister immediately went out and purchased capability in the private sector, ICU beds, ventilators, support, brought to bear the national capacity in health. So sitting next to me, as people would know, is Professor Elizabeth Scott, who was a little bit late because she was actually taking care of people before she rushed to join us on the webinar here this evening, and has been responsible for setting up the use-based service at St Vincent's Private Hospital, where St Vincent's Private invested in something that we didn't up until 5 or 6 years ago. We had no capacity to divert young people, in fact, away from our services where our public hospitals would not admit them, and now we've had some capacity to do that. Now, of course, that's only in the eastern suburbs of Sydney and only available in certain ways. For those who are interested, they could hear Liz talking to Geraldine Doog on Saturday Extra, and I suggest you get the podcast from again, because Liz, you were making the point that in your hospitals and elsewhere and somewhere else, people are being turned away. Young people are being turned away. Other people are being turned away from care in the way that David was describing at the outset. So I want to ask you about this engagement of others, where things are really at. And as we see this increasing turning people away, which just creates the sort of churn that David was talking about, and particularly the failure to engage people with complex problems, the missing middle Pat was alluding to, those with care on an ongoing basis. To what extent can we grab that capability in the private sector or grow it through further investment at this time of national crisis?
So thanks for that. So, I mean, the first thing I would say is that we have been overwhelmed by the demand on our service. So, and Geraldine Doog was asking me, but is it new, or is this how it has always been? And it's certainly there is a new imperative. And certainly there are people, obviously, who are now coming for care who didn't during COVID, but we see new presentations. So we have now large numbers on our waiting list. We have large numbers waiting to see our community multidisciplinary care teams. And we are in the situation of having to turn people away from care all of the time. And these are not people with, very serious, longer-term, complex conditions, such as the one that David is describing for his daughter. And I do not want to be in the same position as intensive care specialists in other parts of the world, where I'm the person that has to decide who gets into care and who doesn't. That is incredibly depressing, and that is a sign of a system that has failed. What we have seen with COVID is this rapid mobilization, the use of technology in practice, which has been dramatic, and also the mobilization of health systems and buying capacity from the private system. So we've had our private hospital that has been empty, waiting for COVID cases to arrive because the government has been able to do deals. We have the same opportunity to provide capacity within the private system and the expertise that sits in the private system, which is currently not, I don't think, being efficiently utilised. So we do have capacity, and I think there is an urgent need to do the same thing that we've done with COVID, to really look at the resources and mobilise the system to provide the type of care and intervention that people need to prevent some of the deaths of despair that have been described overseas that are predicted by this modelling.
So Liz, can I just ask that, because one of the issues that Pat's raising, I think an issue that we've been fighting about, and Sebastian Rosenberg's been tweeting on the Q&A, we've been arguing about models of care and many aspects of private care in the moment, which is not really private, it's federally subsidised to small businesses, actually is quite isolated and is quite separate and it's quite disconnected much of the time from the national kind of effort. So the sort of models of care that you're talking about, and we've been talking with other insurers and private providers, is a different model of care to that which has traditionally been provided in the private sector in Australia. So can you just tell us a little bit more, Liz, about the other work that you've been doing with Holt Street and other practices to transform what so-called private practice is to be something that actually delivers multidisciplinary, ongoing, team-based care that Pat was talking about?
Yeah, so working within the resources that we have within the MBS framework, we have put together multidisciplinary teams based on our Headspace model that have been able to provide some of the complex care and the ambulatory care that people need, actually taking care to people's homes and providing care in those places. And obviously the capacity to do that now with telehealth, but really with digital enhancement, with digital platforms that would allow us to stay connected with and track people over time, will really, I think, provide the innovation. It will allow us to really provide capacity where just doing more telehealth individual consults does not really help with the scalability of the system. We really need to take things to the next level.
So some of the other innovations people might not be aware of, but also working with communities in a particular way. So I'm struck that we work, a lot of this work is in the eastern suburbs of Sydney, and particularly the Jewish community in the eastern suburbs of Sydney. Rabbi Castell is on our National Mental Health Commission, have actually supported some of the housing support, some of the transitional support, so to particularly provide for families in crisis, for young people in crisis, that surrounding areas. So I think one of the issues for us, again, emphasis by some of Sebastian's questions and others, is there's other sets of factors, and I think John's comments, things that are affecting homelessness, things that are affecting families in crisis, in Joe's model, things around domestic violence and drug and alcohol use. You know, and I'd be interested in Simon's comment. You need to know that people are going back into safe environments, and the environment use the point of crisis to actually often work with those other agencies to make sure that we are not discharging to no care or to a very unsafe situation. Simon, do you want to comment about, you know, we often need to take the opportunity of crisis to work effectively with other partners?
Oh, yeah, absolutely. And I think, you know, I remember it was actually only a few weekends ago, and I came on a Sunday morning, and patient had been cleared by the mental health team for discharge. And I went and had a chat with him, and he had a couple of tablets to take, but no clear discharge plan. And he said, look, it doesn't matter all the counselling and all the tablets, all the pills that you give me. If I'm discharging and I need to live in the back of my car, my depression is not going to go away. My anxiety is not going to go away. I'm still going to feel as though I'm living a life at risk. So I think linking into other services and ensuring that we try and address, you know, some of the social determinants of sort of healthcare outcomes, and we try and actually put more effort into ensuring people are living in environments that are supportive where they can access care, either pre-coming to the ED or post-leaving the ED. I think, you know, that's vitally important.
So I think in the COVID-19 response, which is the kind of lens which we're looking at this through, and as John was alluding to, we're going to see more of that. We're going to see more of the fact that people have a combination of factors, whether it's job loss, family disruption, unstable housing. And it's often the case, and a crisis is a crisis, but it's often an opportunity to actually bring together. So the challenges of that, and whether we've been good at that in mental health. So, I mean, I think many of us accept Pat McGorry's basic and others' basic assumption. Of course, we've been under-resourced, but we also need to behave differently in those partnerships and in different sets of areas. Now, along the way, we've gone well over time and addressed a number of these particular issues that have been raised. I would just like to come back to David, who was kind enough to share his family's experiences at the start. David, are there comments that you would like to add or challenges that you'd like to leave us with before we try to continue with this work?
Thanks very much, Ian. I found it very, very interesting to listen to all the presentations I have to say, and a lot of it, I've listened to things and I thought, wow, it would have been nice if, if we'd had that. I did make a few notes, and obviously as a parent, the most important thing is the well-being of your children. So, coming at it from that point of view, I have to say with this whole revolving door business of calling emergency services and my daughter going in and then being discharged, I have on occasion felt completely stumped and desperate. You think, well, what next? Where do you go from here? I have honestly contemplated and have made and am in the process of making inquiries about getting help overseas in a place where I've heard that there is effective mental health treatment. One of the things I think that has struck me about the way the system is structured is that it's all about waiting until some level of harm has arisen before the system will allow action to be taken, at which point it may be too late. From my point of view, it would be far better if the system was designed to prevent people people with mental health from getting to that stage. So particularly in terms of suicide and self-harm, I know one of the presentations mentioned that, with my daughter's situation, if she were to go into hospital and she wasn't having suicide ideation, she's still having a very serious issue. So it'd be nice if that were able to be dealt with. The point was also made about the way it's being done at the moment, especially through the ED being traumatizing. And that certainly has been the case with my daughter. And not only that, but she's lost faith in the system. And I think that impacts on her ability to open herself to getting this kind of help. And I suppose with all of this, one of the other things that I have made investigations about is ways around the legal system. Are there, especially because my daughter's now 16, she gets to decide for herself. She's not really in a position to decide very rationally what the best thing is for her. Are there ways around it that I could take as a parent? And I've looked at those sorts of things. For example, applying for guardianship. I am a guardian in terms of her age, but not for mental health issues. So that's one of the things I've looked at as well. So I just wanted to share those things with you, from a parenting perspective.
So David, I just can't help but be so struck that you're in a situation where you are seriously considering taking your daughter overseas. Australians have a belief that, we have the world's best health system. We pat ourselves on the back continuously. And I'm continuously asked, well, where is it better? And I'm afraid to say, you're not the only parent that I know of with a daughter or with a child with a complex problematic and adolescent that is actually thinking about where are their alternatives. And I think the reality is for Australians, we need to hear that. We need to think about it. We need to stop and dwell on that. And in the clinical leadership we have, in our roles within our communities, and in the advocacy that we have, and those of us that have voice in this particular discourse, we just really need to stop and hear that. That if that's the situation we've reached essentially pre-COVID, what will be the situation as COVID progresses on an ongoing basis? I hope that across the discussion tonight, people have heard about where there are innovations. They have heard where there is leadership. We do present the modelling not to scare people, but to show continuously where strategic investments would make a difference. I think what is underreported in some of the public commentary I'm associated with, it shows the bad side. What our modelling shows is what can work effectively in combination, and where there needs to be innovation and urgency. I guess my frustration is I still have a strong sense of real complacency, and that if we don't talk about what the situation actually is, government responses and societal responses will be slow. We talk about more integration, more federal state. I think this involves every hospital, every emergency service in all of those places. I'm very grateful to people like Simon for the leadership that he's shown in those emergency departments to work with complex systems, and to the other clinical leaders that we've had the pleasure tonight. But I'm particularly grateful to David for sharing his family experiences with us. For those who are interested in receiving more information about resources that are out there. A slide will come up shortly showing other resource settings that we have. We have a series of other webinars that we have promoted in these particular areas about digital mental health, about flattening the curve and where we go. These webinars are possible due to the support we have through the NHMRC, through our Centre of Research Excellence Youth E, but also to a number of other private and philanthropic supporters of this particular area. Some of the issues relate to education. We are pursuing very actively with our relevant staff, and there are a range of people who are interested in finding solutions, and we're very grateful to them for their investments, not just in youth mental health, but across the board. It is an ongoing dialogue. We hope to use these webinars and these formats. Some have asked about ongoing advocacy. I'd suggest that you get a hold of these webinars, discuss them, take them forward, distribute them widely. This will be an ongoing and I hope urgent discourse that we are all part of for the community in which we live. I'd recommend a podcast to you from Sydney Ideas from last week on the future mental wealth of Australia with Alan Fells and Jeff Gallup and others in terms of how we actually mobilise society more broadly in terms of economics and education. But within that, the health sector plays a key role. And hopefully in terms of our own work, that will continue to be a focus of our NHMRC Centre of Research Excellence, our partnership with our colleagues such as Simon and the emergency sector. We do look forward to particular ways forward, potentially from the Victorian Royal Commission, certainly from the Productivity Commission inquiry report due shortly, and really what is happening at a federal level. We have seen responses from the Federal Health Minister. There is a new Deputy Chief Medical Officer, Dr. Ruth Vine, as part of the Australian National Committee that is looking at these health threats. But I think we all need to be part of that discussion. On many, many future occasions, mental health has been discussed. I must say I'm old enough to know that there's a 25-year national strategy talking about integration of these issues. Now is the time for serious action. Thank you for your participation this evening, and thank you to those who've joined with us in this discussion. Good evening.